Hello, welcome to our conference session titled Understanding Aplastic Anemia. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our Sorry about that. It seems like we had some back talk there, so my apologies. I'll start again. Welcome to our session titled Understanding Aplastic Anemia. Thank you for joining us. I'm Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize our generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, type your question in the Q&A box, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Ronald Paquette, who is the medical director and member of the blood and bone marrow transplant program at Cedars-Sinai. He is a physician and researcher who treats patients with hematological disorders, including aplastic anemia, myelodysplastic syndromes, leukemias, and lymphomas. He attended medical school at Ohio State University, completed his internal medicine residency and hematology oncology fellowship at the University of California, Los Angeles. He was previously a faculty member at UCLA before joining Cedars-Sinai Medical Center. Dr. Paquette is a member of the AAMDS-IF Medical Advisory Board. With all of that said, it's my pleasure to welcome Dr. Paquette.
Thank you, Lee. It's my pleasure to speak to patients with aplastic anemia. I'm giving, I've done this before. These slides, if you attended my session before, some of these slides will look familiar because I'd like to give general information, and some people are new to this disease. Other people have come back to have more sophisticated questions because they have been dealing with this for a longer period of time. But I kind of give a general overview and lots of time for questions because I know that there are many things that I won't address specifically with the slides that I have here. Just kind of like a general introduction to the disease. So I'll be talking about aplastic anemia today and now COVID at the end. So if you have COVID interests or concerns or questions, I have a number of slides. You have to wait all the way to the end to see those. So aplastic anemia is a bone marrow stem cell disorder. What's the stem cell? The stem cell is the blood forming cell that gives rise to your red cells, your white cells, and your platelets. And in aplastic anemia, they have been significantly reduced. And we distinguish aplastic anemia from other diseases in which there can sometimes be reduced number of cells in the bone marrow, like myelodysplasia or leukemia. As I said, the peripheral blood typically will have low numbers of white cells, red cells, and platelets, although early on in the course of the disease, just platelets can be affected preferentially. And so it can be a little bit tricky to make the diagnosis if someone presents early. What causes this disorder? Well, it's an autoimmune disease in which the immune system attacks the bone marrow stem cells. We know that some individuals are predisposed based on a specific tissue type or HLA type, but there's no screening test that allows us to say who is likely to get it and who is not. We know that this is an immune disease because killer T cells are oftentimes observed in the bone marrow. So guilt by association, we see them in the bone marrow, we see the damage that's been done, and we assume that they're directly involved in the killing or suppression of the bone marrow stem cells. We particularly know that this is an immune disease because there's a very, very high rate of response to immunosuppressive therapies that I'll be talking about as we move forward. So this just shows some pictures of what an aplastic anemia bone marrow looks like over here on the left. And here's a normal one on the right side. This is maybe a 50-year-old. These clear areas are the fat. The other areas with little dots, these are the nuclei. These are the cells in the bone marrow. This is the bony spicula here. But these are the cells that are making your blood, basically making your blood cells. What happens in aplastic anemia is that the cells that give rise, the stem cells that give rise to all these cells are killed off, and you can see it looks like a wasteland over here. It looks like there's been a nuclear accident. The cells have been markedly diminished and destroyed by the immune attack. Again, what causes it? We know that there's an abnormal immune response. It's like rheumatoid arthritis or lupus of the bone marrow, where the immune system is attacking normal cells. In some rare instances, this can be an inherited disease. We actually call it something else, Fanconi's anemia, which is typically diagnosed in adulthood, which on the surface of it, the bone marrow looks a lot like aplastic anemia, but it's due to a genetic defect. There are other types of mutations that involve these genes that encode components that generate the ends of the chromosomes called telomeres. A small percentage of children and adults can have mutations of so-called telomerase genes called TERK and TERT. And those are oftentimes screened for at tertiary centers to determine if someone has these mutations underlying their aplastic anemia. There can be mutations in a variety of different genes that are oftentimes also implicated in myelodysplastic syndrome. And there's a whole lecture following mine that will be discussing the gene mutations that occur in myelodysplasia. The same genes can be mutated in up to 50% of aplastic anemia patients. There are some that are unique to aplastic anemia as well. How these are implicated in the disease process is still being worked out. Whether they're cause or effect of the immune response, it's a little unclear, but nevertheless, they are associated with the disease in a significant number of individuals. We know from way back that certain medications are associated with aplastic anemia, and although any one medication is only rarely implicated in causing it. So non-steroidal anti-inflammatory drugs are probably one of the most commonly used drugs here over the counter, right? And this is Motrin, but nevertheless, statistical analyses have demonstrated that prior use of anti-inflammatory drugs on a regular basis seems to convey an increased risk of aplastic anemia. Sulfa drugs as a class is another group of medications that have implicated in aplastic anemia, and they include a wide variety of medications, including antibiotics, sulfonylureas that are used for diabetes, and Lasix, for example, diuretic. Some seizure medications, the older ones, have also been known to be associated with aplastic anemia, particularly Tegretol, and then some of the older rheumatologic drugs as well. Some patients, rarely, about 2% of cases, will have an antecedent hepatitis, which is an autoimmune hepatitis, which can then subsequently be also associated with the development of aplastic anemia. And this is a rare phenomenon. So I'm not going to spend a lot of time about the gene mutations. I talked about the Fanconi's anemia, which is actually a different disease that looks just the same. Then the TERK and TERT mutations that occur in telomerase associated mutation. And then the other mutations that occur in up to 30 or 50% of aplastic anemia patients can be ones that are associated almost specifically with aplastic anemia called B-core. Patients who have these mutations actually have a better response to immunosuppressive therapy than the average aplastic anemia patient. PIG-A is the gene mutation that's associated with paroxysmal nocturnal hemoglobinuria. And this can coexist to a lesser extent or a larger extent. The population of cells with these mutations can be small, and the disease can look just like aplastic anemia, or the population can be large, and then it looks like PNH. You'll have a lecture by Dr. Eileen Weitz from USC, who is a world expert in PNH, and she'll discuss more about this. But when the PIG-A mutations are present in an otherwise aplastic marrow, those patients also have a better response to therapy. A variety of other mutations, most of all these things, other mutations tend to occur in myelodysplastic syndrome, and yet the bone marrow is aplastic, and we would call it aplastic anemia. Nevertheless, certain mutations, like the ones I've indicated here, ASXL1, RUNX1, if those are present, there's a higher risk of eventually evolving into myelodysplastic syndrome or even acute myeloid leukemia over time. That's why we look. So why is this information valuable? This helps us, it's helpful, especially if someone has high risk mutations or multiple mutations in their bone marrow, because we know that that would convey a higher risk of a second blood disorder, myelodysplasia or AML. And we might, if it's a younger person, we might say, well, this is a strong reason to consider transplant over immune suppressive therapy, because immune suppressive therapy won't make the mutations go away. They'll persist in the setting of immune suppression. So if it's a younger person with high risk mutations or multiple mutations, that would be a factor that we would consider in determining whether transplant should be the best therapy for that individual. So there's you've already got a sense of it, a lot of these bone marrow failure diseases are related, and I've listed them here. Pure red cell aplasia is another immune-related bone marrow suppression condition, which is also mediated by the killer T cells, but in this situation, they're primarily directing their attack against red blood cell precursors, so only the red cells are low. PNH, we touched on, and you'll hear about later. Large granular lymphocyte leukemia is a killer T cell kind of proliferation in which the T cells are primarily directing their suppression against the white blood cell fraction, and to a lesser degree, the other cell types. So typically these patients present with very low white counts. And then myelodysplastic syndrome, you'll hear a number of talks about MDS later today. It's a Venn diagram that you've seen over and over again, which shows this, as we go this way, the T cells are more involved in the causation of the disease, and then the degree to which bone marrow failure is present is on this axis. Aplastic anemia obviously has both low counts, the most severe counts, severely low counts are seen in aplastic anemia, and of course T cells are implicated. Myelodysplastic syndrome in general has less severe suppression of the blood counts, and T cells probably play a lesser role in that situation, as an example. But there's a lot of overlap. Like I said, the gene mutations that occur in aplastic anemia, by and large, can happen in myelodysplastic syndrome. Aplastic anemia can have abnormal populations of T cells, just like in large granular lymphocyte leukemia. PNH can have, and aplastic anemia can share the same gene mutations in a proportion of the cells. So there's a lot of similarities, particularly at the molecular level, and the involvement of the T cells in these disorders. So how do we classify aplastic anemia? So why is this important? Well, this is important because the main treatments that we use for aplastic anemia are bone marrow transplant or immunosuppression. How do we pick which one to use? Well, and you could use lesser degrees of immune suppression than using ATG, for example. So we reserve ATG and transplant primarily for patients who have severe disease. What's severe disease? Well, the neutrophil count should be less than 500, the platelets less than 20,000, reticulocyte count should be less than 20,000. Two of the three have to be present. Reticulocytes are the baby red cells that are released from the bone marrow. Normal people will have them in the circulation, and if they're significant, normally it would be around 50,000 to 60,000 in a normal person. But when they're very low, less than 20,000, then hardly any red cells are being produced. And of course, that ends up being associated with anemia, which can be severe and profound. So we gravitate aggressive therapies for patients who have severe disease. The more severe the disease, the more likely we're going to use something aggressive like a bone marrow transplant to treat it. Very severe, and this goes even more so for very severe aplastic anemia, where the neutrophil count is less than 200. In general, the response to immunosuppression is less the more severe the disease. And so transplant would be more strongly considered in the setting of very severe aplastic anemia. Moderate aplastic anemia has significantly higher counts than the severe version, and the pathogenesis is probably a little bit different. And actually, there's no standard therapy for moderate aplastic anemia. We'll often use immune suppressive therapy for these, but we know the natural history can be that some patients can have these low counts for many years and not require any therapy. Some will have their blood counts recover spontaneously or gradually over many years. So when you apply treatment, is very individual specific, like if things are trending down progressively, that might be a consideration. But anyway, moderate aplastic anemia is a unique situation that requires individualized considerations of treatment. So what options do we have? Well, I've already mentioned transplantation. Allogeneic means that we're getting the cells from somebody else, related or an unrelated donor, or possibly even an umbilical cord blood a sample. Immunosuppressive therapy, and then hematopoietic growth factors have some role in this setting. Hematopoietic means making blood cells grow. So what about bone marrow transplantation for aplastic anemia? I'm not going to delve, this is more of a scientific slide. It's just to guide my discussion a little bit. We tend to reserve this for younger patients in the first line. What's a younger patient? Well, that's a moving target, because as transplant has become safer and more effective, younger patients are become older. So I think we would consider doing a bone marrow transplant as initial therapy without doing anything else first in patients who are 55 years of age or younger. And the younger the person, the stronger we consider this option, because we know that outcomes are significantly better for younger people. You can make any cutoff you want, but in retrospective analyses, there's patients who are less than 40 clearly do better than patients who are older than 40. But you could say the same thing for 30. You could say the same thing for 50. Younger patients just do better because the complications are less. The survival is better. They tolerate the treatment better. They have less, they have less complications related to the procedure. So of course, younger patients would be more likely to get a transplant, but we don't discriminate. If there's a 60-year-old who has very severe disease, we might think about doing a transplant for a 60-year-old as initial therapy potentially, depending on if they had a healthy younger sibling who was fully matched. Yeah, so it's not an all or none phenomenon. What I would say is that important is that someone who has severe aplastic anemia should be evaluated urgently at a transplant center, because this decision can't be made outside of a place where transplant can actually be applied, or a place where they actually do transplants. And because this decision is so important, evaluation at a transplant center, I feel, is critical, the critical first step to therapy for someone with severe aplastic anemia. The treatment that's given before the cells are infused involves chemotherapy. We call it fludarabine, we call it the cyclophosphamide, and we give anti-thymocyte globulin, just like we do for immune suppressive therapy. These therapies are all directed to suppress the recipient's immune system adequately so that the donor cells can take hold in the bone marrow and grow. If the immune system is killing the person's own cells, if you don't give something before infusing somebody else's cells, of course, they're going to be killed off by the immune system as well. And we call that graft rejection, which can happen even though we can give this immunosuppressive therapy before cell infusion. There's a couple of different ways to get cells. We can get them from the bone marrow, or we can get them from the peripheral blood. Randomized studies have shown that using bone marrow is preferable to using peripheral blood cells because there's less graft versus host disease, which is a complication in which the donor cells attack the recipient. We use medications to try to prevent that, called cyclosporin, methotrexate, to try to prevent graft versus host disease, but it's not 100% effective. And if the immune cells from the donor decide to attack the skin, the liver, or the intestines, we call that graft versus host disease. And we have treatments for that as well, but it's better to avoid it if possible than to treat it. There's a growing use of half-match donors for transplant in aplastic anemia, and we've used a very specific therapy following the transplant called Cytoxan to prevent the immune attack against the recipient. This is probably going to have wider use even for match transplants in the future because it's been very highly effective in the half-match transplant setting, and we use this exclusively for all of our transplants here at Cedars-Sinai, although we haven't done we're just starting to do haplotransplants in aplastic anemia now. Survival is excellent. Overall, it's about 80%, and I have some newer data to show you. It's better to do a transplant early rather than do it later. Why is that? Well, with time, patients get more and more transfusions. They get sensitized to donor proteins that might increase the risk of graft rejection. With more transfusions comes iron overload, which we want to try to avoid. And iron overload can cause damage to other organs at some later point in time. So doing it within the first 2 years of diagnosis has been shown to convey an excellent outcome, but if you wait longer and longer to do the transplant, the outcomes are somewhat less ideal. I mentioned younger patients do better, but that's, we factor that into the initial decision making. What are the risks of transplant? And these percentages are lower than what I have here. This is a little bit of an older slide because, again, transplant outcomes have improved, but this just lists the risks. So there's a possibility, and it's hard to make this super low because we don't use very intensive therapy before the transplant. We try to avoid toxicity to the individual with the so-called conditioning regimen. So we have to accept about a 10% risk of the graft being rejected and having to go through the process a second time. There can also be graft versus host disease, which I've mentioned, which if it happens in the first 100 days, is called acute. And it can be potentially severe and inconvenient, or it can be later after 100 days or even after a year, and it can become a chronic disease that can require long-term therapy potentially. Having serious infection can happen when the blood counts are very low. As you'd expect, patients come into the transplant with very low counts. And that's another reason to do a transplant earlier versus later. If someone gets a fungal infection, for example, when their counts are low, it's hard to that means they'll have an increased risk of perhaps a reactivation of a fungal infection during the transplant when their counts are low and they're on immunosuppressive therapy. So infections can happen even in patients who are getting a transplant as their initial therapy when their counts are very low. Bacterial infections, fungal infections, and viral infections can happen. And that in a small percentage of patients, this is primarily the thing that affects the survival at the present time, although we have better and better ways of treating and preventing infections. And then even when a transplant's been optimally successful, the exposure to the immunosuppressive therapy can convey an increased risk of solid tumors down the line, especially if someone's required immune suppressive therapy for graft versus host disease. So I stole this slide for the Center for International Blood and Marrow Transplant. They collect data on the outcomes of all transplant patients. And as you can see, the survival of people who are getting transplant for aplastic anemia has progressively improved. Things were kind of static between 2001 and 2010 with about 65% survival at 5 years. But look at now, the more recent data between 2016 and 2018 shows closer to an 80+% survival. And this is for adults. If you look at kids, it's way up here. And I apologize, I don't take care of children, so I'm showing some bias here. But the outcome for children, for particularly individuals less than 18, is superior to this, because this includes all adults who have been transplanted, regardless of the timing of the transplant. Kids are way up, much higher than adults, and so it's oftentimes the treatment of choice for children for that reason. But again, the methodologies that are being employed has only shown progressive improvement as the years go by. So what about immune suppressive therapy? What does that involve? Well, the long-standing treatment is called anti-thymocyte globulin. What is that? Well, it's made from horse blood. Can you believe it? How does that work? Well, they inject horses with fetal T cells, and then the horses make antibodies against the human T cells. And those antibodies, when infused into an individual, will kill or suppress the T cells that are causing the bone marrow suppression. So you kill off the T cell. That's the theme of immune suppressive therapy. The T cells are causing the problem, so kill or suppress the T cells. And so ATG was the first treatment going back to the late 70s, early 80s that actually made a difference in treating aplastic anemia patients. And so we use that in patients, primarily patients who have severe disease. It could be used in more moderate situations if clinically indicated. It's given as 4 doses. And what about ATG should you know? Well, it has to be given through a central line. So people need to have a PICC line or some long line that goes to the right side of the heart. So otherwise it will cause injury to the vein. So if you try to give it through a peripheral vein, it will cause a lot of irritation and the patient will be very unhappy. So a catheter has to be put in first to allow the administration of this medication. Because it's a foreign protein going into your body, allergic reactions can happen. So you have to give pre-medications with Tylenol and Benadryl and steroids to help prevent an allergic reaction, which can happen. The other thing that it does is that when you infuse this foreign protein, you mount an immune response, just like you would to a vaccination. But it's a huge dose of foreign protein, and it circulates around in your bloodstream for up to a month. And so what happens during that month time? Well, you develop antibodies. You develop antibodies to those foreign proteins, and then your antibodies bind onto those antibodies, and those are called immune complexes, and they can be deposited into the skin, into the joints, and cause a bad rash, joint pains, and we call that serum sickness. How do we treat or prevent that? Well, we give high doses of steroids for the first 2 weeks and then tapering thereafter to prevent serum sickness. And so that's an important component of the ATG treatment. If you don't give steroids to prevent it, the serum sickness can be pretty bad. Even if you give steroids, you can't 100% prevent it in everybody. And because there can be side effects from high dose steroids, we try to walk a fine line between suppressing serum sickness and causing steroid-related complications down the road. So that's what I can tell you about ATG. It doesn't work right away. When we use the ATG by itself or with cyclosporin, it would take 3 months before we typically see some response. And in the short term, because this is a lot of a foreign protein in your body that can bind on to your white cells, onto your platelets, and cause the numbers to go lower, especially the platelets for the first month while it's still circulating in your body. Patients who get ATG will have higher platelet transfusion requirements than before they got the ATG. So that's something to be aware of, because it causes the person's platelets to be cleared more quickly than if they didn't have the ATG floating around in their circulation. So something else to be aware of with ATG. Again, I because of all these things and because aplastic anemia is rare and I mean ATG is not commonly given in the community, I would encourage, again, treatment of aplastic anemia, severe aplastic anemia, be done at a tertiary center where there's a lot of experience in making the transplant decision and in administering the ATG and managing side effects that occur with it. Again, I'm reiterating that point, but I of course I'm biased because I've always been working in an academic center, but I think the outcome of the patient can be improved by having it done in a place where it's done more often. What about cyclosporin? Well, randomized trials show that adding cyclosporin to ATG improved the response rates. What's cyclosporin? So cyclosporin is a medication that prevents the activation, it prevents the activation of T cells. So again, T cells are causing the problem. If we kill them with ATG and then suppress them with cyclosporin, we have a greater degree of response to the immune suppressive therapy. There are standard doses for using cyclosporin. There's a range of doses that can be effective. There can be side effects associated with cyclosporin. These things all have to be taken into account in determining the dosing. Original studies used it for 6 months and then it was stopped. I have always followed a course of giving it for prolonged periods of time and tapering the dose down very slowly because relapse can happen. You know, this is an autoimmune, it's like a rheumatologic condition. So the current therapies for most rheumatologic conditions aren't curative. And I would say using ATG and cyclosporin is not curative in many patients. And so a substantial proportion of patients, perhaps 50%, will require cyclosporin long-term. And so just stopping it is really inviting a rapid relapse of the disease, which nobody wants to see. If you taper it slowly, which is my common practice, very slowly, in fact, you can determine if patients really need it, and you can determine what the minimum dose is that's necessary to maintain the response. And therefore, you can give the minimum dose effective to maintain the best counts possible. And that's my practice, and it varies from place to place. Eltrombopag, also called Promacta, is the newest introduction into the regimen. And what is that? Well, it is an oral medication that binds on to a growth factor receptor. That growth factor is called thrombopoietin. What does thrombopoietin do? Well, it stimulates the production of platelets, but remarkably, this receptor is also present on cells in the bone marrow that give rise to white cells, red cells, and platelets. And so not only can it increase the platelet count, it can increase the white count and the red count as well in aplastic anemia when used as a single agent. When it's combined with ATG and cyclosporin, the response rates look markedly superior. So for ATG alone, 50% response rate. For ATG with cyclosporin, 65% response rate. When you throw in Eltrombopag, the response rate can be as high as 80 to 90%. And the complete response rates are much higher too. Complete response meaning all the counts are normal. And the added bonus is that the responses happen faster. So we see with the 3-drug combination, we see responses at a month, and good response, and pretty good the start of responses at a month. And they're much better than they used to be. This has really been a significant advance, I have to say, having seen treatment evolve. This has been perhaps one of the most significant additions to the regimen that we have available for aplastic patients. The other thing that's important is that these responses, they can be delayed, and that thinking about some additional treatment, I've seen physicians who haven't had a lot of experience say, oh, it's a month later, and when do we do the transplant, or when do we do something else? It takes patience. And so depending on the clinical situation, doing something else might not be until 6 months after the ATG is given, for example. So patience is important. Knowing when to think about an alternative therapy is important. Doing something else at 3 months is oftentimes too early. 6 months would be a reasonable time frame depending on the clinical situation. So that's important, and it should be, again, individualized depending on what the counts are doing and what the clinical situation is. Survival is excellent, and it's progressively improved with better supportive care, with the use of L-Trombopag. And so, everything becomes a moving target. When do we use immunosuppression? When do we use transplant? It's kind of a happy conundrum, because like when both treatments get better over time, it makes it a little bit harder to know which one you would use in a specific situation. So again, having that decision made at a tertiary center is important. What are the risks of immune suppressive therapy? Well, while you're waiting for the blood counts to recover, infections can happen, just like with transplant. And we'll oftentimes gravitate to transplant, for example, because that the blood counts are going to come up 2 weeks, after the cells are infused, for example. It's a lot more variable when you use immunosuppressive therapy. And as I said, it could be 3 months, it could be longer, and it's much more gradual. Like with a transplant, a patient could have normal counts a month after the transplant. Very few patients getting immune suppressive therapy will have normal counts in a month. I just say nobody has normal counts a month after they get immune suppressive therapy, and it can be years later. And so infections can happen, bleeding can happen, again, especially during the first month after ATG is given, because the platelets and the platelet transfusion requirements tend to be higher during that time. We know with long-term follow-up of patients who get immune suppressive therapy, other blood diseases can happen. Acute myeloid leukemia or myelodysplastic syndrome happens in 10 to 15% of patients after 10 years. Now, with the testing for mutations, that has to some degree explained the risk for these things developing. In that, 30 to 50% of aplastic anemia patients can have these mutations that are associated with these diseases. And when high-risk mutations are present at diagnosis, or when multiple mutations are present at diagnosis, we can again say that it's going to be more likely, more than the 10 to 15%, that they're going to have myelodysplastic syndrome at 10 years. And so again, that may help us to consider transplant over immune suppressive therapy in that setting. PNH can be present at the time of diagnosis. A PNH population can be present at the time of diagnosis, or evolve later during the course of the disease. Even when the counts are normal and have a full, complete remission, PNH can show up later. We don't fully understand why that happens. Well, actually, we don't understand why that can happen, why that's preferentially seen in the setting of patients who have had aplastic anemia. The most important complication of aplastic anemia treated with immunosuppression is relapse. And as I said, this was actually validated in the trials of L-Trombopag at the NIH. They had the practice of stopping immune suppression at 6 months, and that's what they did initially on the trial. And then they had half the patients relapse thereafter, whereas when they used more protracted cyclosporin, then patients had much more durable remissions, although they stayed on cyclosporin for a more indefinite period of time. Relapse is the biggest risk of immune suppressive therapy. And that's why cyclosporin is important to maintain remissions in a substantial proportion of patients. And so again, that's why I follow the practice. And any of my patients are on the call know how they have to be patient. Yeah, that's the only way I do it. But being very patient with the tapering. And again, this is not this. I mean, there's nothing written in a book about how you're supposed to do this. I think there's a lot of individualized approaches to way cyclosporin is managed. I should say that cyclosporin was used in all the trials, but a very similar related drug called tacrolimus that we use more often in transplant also is effective. And what's kind of nice about tacrolimus is that if you've had gun swelling from cyclosporin, you can appreciate what that's like. But tacrolimus does not cause the gum swelling that you see with cyclosporin, and you can substitute it. There's a lot less experience using it in this setting, but it really is effective. I'd like to see more data on the use of tacrolimus because I think it's better tolerated, but we just don't have enough experiences to routinely substitute it in that setting. What about white blood cell growth factors? And in particular, GCSF, the first white cell growth factor, GCSF was Neupogen, but they have other ones now. They have Granix, they have Zarxio, because it's off patent now. So there are bioequivalents of Neupogen that are cheaper and available. Well, these can make the white blood cells go up. Why don't we use them routinely in the initial management of aplastic anemia patients? Well, that's because randomized trials have been done. And we know that adding GCSF to the regimen doesn't improve the response rate or the survival. And I mean, paradoxically, the patients who need it the most are the least likely to have some benefit from it. That's partially why it doesn't contribute so much, because patients who have a neutrophil count of 100 or 50, some really low number, those patients are much less likely to respond to GCSF than patients who have a neutrophil count of 300 or 500 or 700. So the more you need it, the less likely it is to work. What's the other problem? The other problem is that if you're pushing white cells when you don't really need them, the stem cells are really busy trying to make cells. I mean, the ones that survive are really trying hard to make blood cells. And if you're pushing them all to make white cells, you can make them at the expense potentially of making other cells that you need, like platelets. So we call that stem cell steal. I think that's a real phenomenon. So you don't want to be pushing to make white cells when you don't absolutely need them and you need other cells as well. The time we would use this is if someone has a low white count and they have a significant infection, especially if it's not being adequately controlled with antifungal or antibacterial agents alone. Then we need help. Then you really need it. Then you need white cells. So yeah, that's when we would use it. Really long-term use of GCSF has been associated with an increased risk of MDS or AML potentially, but that may just be because patients who need it long-term have a predisposition to these conditions, and it may not really increase the risk. So if somebody really needed it long-term because of their clinical situation, then I think this concern shouldn't contraindicate its use necessarily. So not everybody who gets immunosuppressive therapy has a complete response. And the thing I want to point out here is this should not cause chronic anxiety, because if you have any response to immune suppressive therapy, your outcome is excellent. So all you need to do is have a response that keeps you out of trouble, and you don't need to have 150,000 platelets. You don't need to have 250,000 platelets. You don't have to have a neutrophil count of 2,500. You can live with lower counts, and that shouldn't be a cause for concern. If you have routine medical follow-up, it doesn't mean like, oh, I'm free and clear, I can stop my meds anytime I want. Don't do that. Okay, don't do that. But it means that you shouldn't be obsessing or having this be predominant in your mind every day, all day long. And we know statistically that patients who have response to immunosuppressive therapy do very well. What's the minimum? I kind of made these up, but platelets over 20,000, you're not going to need transfusion. You're not going to be skydiving or surfing or skiing with 20,000 or 25,000 platelets, but you can be pretty normal. And so neutrophils over 500, I think that's really conservative. These, if you have these numbers, and especially if they're trending up gradually, just continue, stay the course. I don't know if there's a specific cutoff for hemoglobin. We don't like to chronically transfuse people because of the long-term problem with iron overload and the potential for increasing the risk of graft rejection if you ever have a transplant later. But anyway, just some improvement and numbers out of this range would afford some degree of relief, I would say. And when we get to those numbers, for those of you who have been through that, when we get to those numbers, we feel, I can take a sigh of relief that the worst is over and we're moving in the right direction. So what happens if ATG doesn't work initially? And this is a smaller percentage of patients than it used to be. Or what happens if someone, like we have a relapse slide, so we'll get to that. So what are our options? Well, unrelated donor transplant is a consideration. And this is the reason, again, to present yourself to a tertiary center, an academic center at the time of diagnosis, because even if someone gets immunosuppressive therapy, we look for unrelated donors initially because it can take 3 months to mobilize an unrelated donor. And you don't want to be waiting 3 months if now we really need it. We need it now. We need it now. And where's the donor? Oh, we didn't start a workup, or they haven't been at a transplant center. So doing that initially to get an idea of what the landscape is like, and having a donor available, and we know that they have identified, they haven't dropped out of the registry, is very helpful. A growing option, which I really am enthusiastic about, but again, we haven't yet done our first haplo for aplastic anemia. We've done 1 million of these for other indications, is using a half-matched donor. So for kids, it can be a parent. For a parent, it can be a kid. So I like the prospects of this in the future, and it's going to expand our options and we actually prioritize these over unrelated donors for every other indication. So again, I'm really excited to see where this is going to go. We don't like umbilical cord blood transplant for aplastic anemia. There may be some centers that specialize in this. I would say that's still an option, but we have discontinued the use of umbilical cord blood as a source for stem cells for all of our indications because of reasons I'm not going to talk about here. But again, a place that specializes in doing this, I would say is fine because it certainly can lead to full recovery. But I think there'll be a growing use of half-matched donors over umbilical cord blood transplants and even over unrelated donors as time goes on. Well, if someone doesn't respond at all to the first ATG, a second course of ATG has about a 30% response rate. And the same thing is true for, ATG is horsey, and thymoglobulin is bunny. So you could use bunny instead of horsey and have about a 30% response rate as well. If you're talking about 30% response rates, these obviously are down the list from doing a transplant from an unrelated or haploidentical donor. We would prioritize these for sure over a 30% response rate when the first course of ATG didn't work. But if someone's not a transplant candidate, if they're 77 years old, then yeah, sure, let's do this. Another option is just using cyclosporin for longer. I had patients who didn't respond to immunosuppressive therapy, 2 courses of ATG, be on 2 experimental trials, but I just kept them on cyclosporin, and lo and behold, they are long-term survivors off all therapy, many years later, living normal lives. So thank God I didn't stop it. But like I would say, and luckily we have other options that we can combine with it. So I didn't change this back to L-Trombopag or Romiplastim. This is an injectable drug that does the same thing as L-Trombopag. Both these have activity in patients who haven't responded to anything else. So I kind of like, if someone hasn't responded, using cyclosporin and one of these rhombopoietin-like drugs would be another really attractive option. I should also say that during the pandemic, patients and we were reluctant to use ATG, for example, and the NIH had a program combining L-Trombopag with cyclosporin. I did this for a pregnant patient. She was pregnant and we couldn't give ATG, and then there was the pandemic, and so we never got around to it, and then she responded to the combination of cyclosporin and I did this for a couple of pregnant women, and they have had excellent responses to that combination without ATG. I would say that the responses are slower. That doesn't mean they can't be complete though. So this is another option, I think, for patients who had a bad reaction to ATG or didn't respond to ATG, and maybe they've had 2 ATGs and that hasn't worked. There are these options which I think are also attractive. And then there's experimental trials, which I was too lazy to make slides about, so I'm not going to talk about that today. hope I'm not talking too long. All right, I'm not talking about, there's a whole talk about transplant later on. And so I'm not going to belabor this, but the conditioning is a little bit different, and where we use total body irradiation as an additional immunosuppressive component to the treatment before the cells are infused. I would just mention that. It's not scary, it's well tolerated, but it adds, we need to have more immune suppression to prevent graft rejection, in particular when an unrelated donor is used. And so that's important to know. And all the other things I said about related transplants are also true for unrelated transplants. And I can say with confidence that you can see the outcomes are just slightly lower than having a fully matched related donor. And these outcomes have improved. These are also older, includes older data as well. So these outcomes have also improved, as have the outcomes for using fully matched related donors. And so you can see if you're balancing this kind of survival of around 75% at 5 years, 70-75%, it's going to be better than using immune suppressive therapy if the first ATG didn't work, for example. Why don't we use unrelated donors as an initial therapy? Well, we can't, because it takes like 3 months to get the donor ready. And so you're not just going to be doing nothing for 3 months. And so we use immune suppressive therapy while we're working up the donor options. And because immunosuppressive therapy works so more quickly now, it obviates the need to do a transplant for the majority of people for whom we're looking for unrelated donors. So if someone's responding to immune suppression, we're not going to do an unrelated donor transplant. We're just going to continue with what's working already. Okay, so clinical trials done at the NIH in particular use eltrombopag or Promacta as a single agent for aplastic anemia. And these are patients who had zero response to anything up until that time, as I mentioned. And they've reported their longer term experience with 40 patients, and 50% of them had responses. And eltrombopag, also kind of akin to immune suppressive therapy, does not work very fast. And so responses were seen between 3 and 6 months. And so they recommend, if this is going to be the option that you're going to be pursuing, not giving up before 6 months if this isn't attractive. Don't just stop it because of futility after 3 months. 6 months is a reasonable time to continue therapy. And like I said, it's not just for platelets. 2 cell types improved in 22%, and all 3 improved in 18% of the patients. 50% had platelets, and 18% had all 3 cell types improved. So this looks like a reasonable option for patients who might not have previously had other options. We know that probably long-term therapy is important for many of the patients. Some of them had great responses and then said, do I still need this, and stopped it. But a third of them had to restart drug at the time the data were published because they had worsening counts again. I would expect that to be the case for the majority of patients, quite honestly. But anyway, that would be the expectation, is being on this kind of longer term. But there is a disadvantage, and that is that just like with the GCSF story, patients who are on this drug long term, 18% of them developed MDS-like chromosomal abnormalities, or MDS or AML per se. And interestingly, in this situation, it almost always involves loss of chromosome 7 or the long arm of chromosome 7. It's a very specific abnormality that's seen in patients who are long-term survivors and who have been getting GCSF or eltrombopag for a long period of time. Is it related to the treatment, or is it related to the fact that they've had this chronic condition for so long and that they were able to survive just because but people were able to be salvaged by these treatments and they wouldn't have survived otherwise? I think it's an area of controversy. We don't know. In any case, it's not unreasonable to discontinue treatment for that reason, knowing that the likelihood of responding again when it's reinitiated is almost guaranteed. So unless there's been some development of MDS. Moving on. I'm just going to look at see how much I'm running over. Oh my God, Can somebody interrupt me if I'm talking too long?
Dr. Paquette, we can go about maybe 5 more minutes and then we've
Okay,
got to get to the
okay,
questions.
let's go to the part you guys all want to hear about. Oh, I made too many slides. I'm so sorry. This is terrible. Oh my God. Well, you're going to have questions. I got slides for all the stuff that you want to ask about. I'm going to do COVID at the end. Wow, I have so much to talk about. This is just a fascinating topic. I'm sure you all agree. Oh my goodness. All right, so what about COVID? So I didn't come up with this stuff, okay, because I have had only a small number of aplastic anemia patients who have had COVID or have had vaccinations as well. So I have to defer to smarter people about these things, and so I got a resource, American Society of Hematology, which of course got advice from Dr. Neil Young at the NIH and others. Dr. Patrick Galupo is on the medical advisory committee, and the European Society for Blood and Marrow Transplant. So when you see these little abbreviations at the end of the recommendation, you'll know where it's coming from. So overall, aplastic anemia is a rare disease. We don't know in general how patients with aplastic anemia do when they get infected. We don't have hardly any information. It's being collected, but we'll know a year from now, who knows when. So we don't know what the natural history is going to be. So all this stuff that I'm telling you is mostly common sense. When possible, I'm just going to go through these quickly in the interest of time. So the recommendations are to minimize blood testing and transfusions, as I talked about earlier at the very beginning, transfusion support if possible, so that you're not being exposed to people in the clinic who might be sick or in the emergency room, God help me, or other places. So try to limit the access to medical care if it's reasonable and it doesn't compromise your safety. 2, if you're going to be getting immune suppressive therapy or a transplant, you should be getting COVID testing. And that's, of course, routine at any place that's going to be doing this to make sure you don't have an infection and that the infection is cleared. Now, the clearance is the tricky part because people who are immune compromised can test positive for COVID for weeks to months and still not be infected at that point. They can still be shedding something that the RNA and not have an active infection. So close consultation with infectious disease may be important to know when someone who's immune compromised has actually cleared the infection. All right, we don't know how giving immune suppression is going to affect a person with aplastic anemia's response to the infection. We expect that it's probably going to be bad. So like using ATG, if it's not absolutely necessary, you should think about deferring it in consultation with your hematologist. And like I said, I've deferred using ATG in some of my patients and just use cyclosporin and eltrombopag as an option in that setting. But ASH says if you have very severe aplastic anemia and neutrophil count less than 200, I wouldn't delay anything in that setting, and neither would they, because those most severe patients really are in a life-threatening situation, and treatment should be started right away and try to manage the risks of COVID thereafter. ATG, as I said, should be limited to patients with severe cytopenias and have, as the EBMT said, immediate risk of death, which is a little too extreme for me, but I think there has to be a significant reason to give it in someone with aplastic anemia, but that is their recommendation. If patients can't get ATG for other reasons, as I said, cyclosporin and eltrombopag are reasonable options. That comes from ASH, or eltrombopag alone, which is what EBMT says. And cyclosporin dosage should not be arbitrarily decreased just because there's a pandemic, because that's going to compromise the response and cause patients to relapse. And so I think that's very reasonable. I like that recommendation, especially since we don't know how cyclosporin is going to affect a person's ability to handle the actual viral infection. Transplant should be postponed whenever possible, and we did defer some of our patients here when possible, especially, and ABMT says, particularly when there's an unrelated donor, patients who are awaiting an unrelated donor have already started and have ongoing immune therapy. So that makes sense because they're already getting therapy. It's not like they're doing nothing. So I think that's also reasonable, but this should be taken on a case-by-case basis. I don't think this is a blanket recommendation, quite honestly, in my opinion. Okay, this is important. Transplant donors, as well as recipients, should be tested for COVID infection. And we've had both donors and recipients test positive and throw a wrench into our transplant plans. What we're doing for particular, and this is an important point, donors should be collected before the conditioning starts for the recipient. Because what happens if the donor gets infected between the time the conditioning starts and the cells are collected? That would be a catastrophe because the patient's waiting, when are my cells coming? Oh, the donor just got a COVID infection, sorry. Well, we would really like to avoid that situation. And in fact, we're making sure we do that for all of our transplants. What about vaccination? This is the questions that everybody has. The risk versus benefit of vaccination favors vaccine administration. That means get it based on the recommendations of the American Society of Hematology, especially if you have other risk factors, like if you're older, if you're obese, if you have diabetes, things like that, that would favor use of vaccination anyway. They say the risks probably are less than the benefits of getting vaccination. And this is what's really with hardly any data. But they say common sense would dictate that getting the vaccine would be safer than getting the actual infection. Patients within 6 months of getting ATG would not be expected to have a good response to vaccination. So if they get infected, though, it might be better to not get the vaccine in the first 6 months. And if infection happens, then we would use an antibody-directed therapy to try to help to mitigate the infection in that setting, provided meets the criteria for administration. Patients getting cyclosporin more than 6 months after ATG can respond to vaccination, but we don't know how effective that would be. And again, if you're in LA and you want to find out and you're on cyclosporin, we have a study for you, and you can sign up and get information about your immune response, both from the antibody and T cell data from your peripheral blood draw. We know the transplant patients would also be unlikely to respond before 6 months. We vaccinated some people just because we had it available. But realistically, we don't start vaccinations until 6 months routinely for any infectious agent. And so doing it later than 6 months is reasonable. And then we would prioritize COVID vaccination over other vaccinations. People who are on immunosuppressive therapy for graft versus host disease prevention or treatment are going to be less likely to respond. Again, it's going to be extremely variable from person to person, and that's the reason to be on the study. And so now there are probably questions. If there aren't questions, I can go back and talk about other stuff. But maybe some of the questions will be related to what I have on the other slides. Sorry, I didn't plan this very well, did I? I should have. But all this stuff is important.
We have a lot of questions, Dr. Paquette.
Oh my God, let's go.
Can you explain the treatment options for moderate aplastic anemia?
Yeah, so that really, if you don't have any severe abnormalities and they're stable, watch and wait is not unreasonable. And again, what I would do, and this is to look and see if it's really to see if there are gene mutations present, because that may affect the way it's approached in the future. So some patients of moderate aplastic anemia really have like a hypocellular myelodysplastic syndrome-like situation. And so knowing what mutations are present may factor into the decision-making about treatment or whether it should be applied, or I think that's still something that's in a process of evolution. For patients who have moderate aplastic anemia and are stable, I watch them. I've had patients, and particularly, I don't know why, patients who are from Korea. It seems I've had a number of patients who are Korean and had cytopenias in the moderate range, and they just stay there for years, actually. And I've had some patients, just like there's a paper that actually was never even published, only an abstract that was presented at ASH one time from Cleveland Clinic. It's fascinating that many patients remain stable and improve without therapy. In patients, but there are others who will progress to severe disease. And when we see that things moving towards that direction, I won't use ATG because ATG has significant irreversible complications, particularly avascular necrosis in a significant proportion of patients. I'll use cyclosporin and Promacta. And I like that because all the effects are reversible, pretty much. Most of the effects are reversible. And it can be efficacious, and it's pretty well tolerated. So that's what I do. It depends on the way the disease is progressing.
Thank you, Dr. Paquette. This question says, great presentation. How much do we contribute exposure to toxic environments or substances to acquiring aplastic anemia?
That's so hard. Epidemiology is so tough. Even just getting drug associations because the disease is so rare. Dr. Neil Young tried for many years in the 70s to establish associations. We know the one that's really clear is benzene. So, there are industrial safeguards. OSHA has very strict regulations about exposure to benzene. There's no question benzene exposure is the one toxin, and that's present in motor, in gasoline to some extent. Organic solvents in particular could be a risk. Benzene can be a risk, and benzene exposure is not only associated with aplastic anemia, but also MDS and AML as well. It was used in rubber manufacturing. It was used in making shoes. And these are real risks in places where there aren't safeguards, like China. They still have literature on this kind of thing. But I think those kinds of exposures are probably vanishingly rare. Almost always there's an immune component. What causes the immune component we're only learning about, but there is some genetic predisposition, which conveys a low but realistic risk in some people. I think toxin exposures are really hard to link in the majority of patients.
Thank you, Dr. Paquette. Our next question is regarding eltrombopag. Does eltrombopag affect the outcome of transplant in any way?
You mean, is it prior exposure? Prior exposure to eltrombopag should not affect transplant outcomes. So if you've had eltrombopag for some extended duration of time, it shouldn't have any impact on subsequent transplant. We don't use it in patients who like to enhance their recovery post-transplant. That would be an interesting study, perhaps, but it's not necessary. The problem is the onset of action is too low to be used when patients have low counts post-transplant. So it's not been really studied in that setting. But prior exposure to eltrombopag shouldn't compromise the outcome of transplant in any way.
Thank you. What are your thoughts of prolonged use of eltrombopag? And it says, is tapering to a low rate, as in cyclosporine, a valid way to manage very severe aplastic anemia without having to face relapses that may eventually come?
That's a challenging question because we don't know. We don't know if the drug is etiologically, if it's linked to the causation of MDS that's been reported in patients, whether it's somehow related to the development of the chromosome 7 abnormalities. There's a suggestion that it might, because, for example, if you look at the patients who are on eltrombopag long-term, they did not have increased numbers of gene mutations, but they did have increase in the risk of developing loss of chromosome 7 or 7q over time. That if it really was so it suggests that perhaps the drug was causing these chromosome abnormalities as we saw with GCSF. Maybe because it's stimulating proliferation, I don't know. We don't know if there's a dose-response relationship between using this, in other words, does using more increase the risk of that particular complication? We don't know. Does using too low of a dose compromise the survival of stem cells? We don't know, because it causes stem cells to grow, but it may also enhance their survival. So if you reduce the dose and the counts go down, are you causing the loss of some stem cells that you would otherwise retain? I don't know how to get to the answer of either of those questions. I think they're important considerations, With cyclosporin, I always try to use the least dose that maintains the stable response, because I know it's being effective. The counts are stable. I know it's being effective. I don't. It's hard to weigh the risks and benefits of Ultramapag in that setting. However, can't answer it. I don't know.
Thank you. How common is LGL with aplastic anemia?
It is, so it's pretty common if you look for it, because and it doesn't. Yeah, that's a good question, because that's actually the pathogenesis of the disease. So like I said, LGL just means that there's a population. What it means is there's a measurable population of cells that are all derived from the same parent. When you have an immune response against anything, there are usually a lot of different proteins that the immune system is reacting against. But in aplastic anemia, it's probably a select number, one or not one, but a very limited number of proteins that are the target of the immune response. And so it makes sense that the T cells there'd be one T cell that'd be attacking a specific protein, and those would expand, and then you would have a positive LGL test, which we call the T cell receptor gene rearrangement. I actually see that in aplastic anemia, and I expect that would be the case because of the nature of the fact that these are all T cells going after one or a limited number of proteins. So it doesn't mean you have leukemia. It means that you have an immune response that's inappropriate against a very specific protein target or targets. So I would bet that depending on the sensitivity of the test, it's going to be pretty common, and that would not affect my treatment in any way. We also see LGL very commonly in myelodysplasia, and you don't know, are they doing anything to suppress the blood counts, or is it just the fact that the immune system knows that something's wrong and it can't fix it? They're kind of futilely trying to get rid of the MDS, and they're expanding, trying to kill the MDS, but the MDS has outsmarted it. So I think these LGL cells can be quite confounding, and they don't mean that it's a separate disease. I think it's just part of the pathogenesis of the disease, quite honestly.
Well, thank you so much, Dr. Paquette. This is all the time that we have for questions. But
you can email me. Just email me, and so that goes.
Some of the questions were regarding PNH, so I would suggest that those questions, please join Dr. White's. There were a few questions that were regarding transplant. Please join Dr. Nakamura's session. He'll be able to help with those questions as well. So thank you so much, Dr. Paquette, for sharing your time and your expertise.
I thought I would have too much time. That's funny. Sorry.
If you would like to watch the session again at a later time, it will be available on the conference platform within just a few days. We there were.
So you can look at my additional slides, and if you have questions, there are things in there that may not come up in routine care, but that sometimes it's important to know about. So I would encourage you to look at those, especially if you've had aplastic anemia and been on treatment for a prolonged time. There are some important things to be aware of, and I gave my email address. I don't know if you can make that available to people to email me as well if they want to participate in the trial or if they want to ask additional questions.
Absolutely. And there were some questions about the slides being available. We can absolutely make sure that everyone gets the slides.
Yeah.
So if you have some other questions, please feel free to send them to us in 3 ways. You can send an email to our help account, which is help@aamds.org. You can call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. Please be sure to visit our exhibit hall today. Our next session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. On behalf of our medical advisory board and team, we are always here to help you and your family, as we have done for the past 37 years. This concludes our session. Thank you, Dr. Paquette.
Next time, give me 2 hours. Actually, it's better in person because people can come up to talk to me. I didn't, usually they'll come up and talk and ask their questions.
Right.
We didn't actually have, sorry, I didn't have enough time for that.
Next year.